We've got another really good a meeting. This is quite cancer focused actually, but we're going to be starting off with Dr. Ginny Ashman, who's going to give us a vaccination update first of all. As usual, the meeting is recorded, so please be aware of that. The speakers will be given opportunity to do their presentation, and then there's an opportunity for everyone to ask questions afterwards. I'll keep an eye on the chat, so if you have some questions there, then if you've not had the opportunity to ask it directly, then hopefully that'll be picked up by the speakers in the chat and get back to you. So I think we're going to just get started in just a few moments, just let a couple more people come in. I suspect the good weather and the summer holidays has probably delayed some people. So we'll just give them a minute or more before we get things moving. Whilst I'm just doing that, I'd just like to say welcome to a observer, Surrender, who's here with us, who's coming to see what we do within the ISOB. So welcome, Surrender, and hope you will gain something from this meeting.
Thank you, sir.
No problem. Good. Ginny, I'll just give one more minute, and then we'll get you started. If that's okay with you?
Yeah, absolutely fine, no problem.
And I've just spotted that we are planning to finish 5 minutes early. So that's 5 minutes back so you can enjoy the weather if we finish on time. Good. Yeah, I think there's a fair few people here. I don't want to keep people waiting now. So would you like to go ahead, please, Ginny? Thanks.
Sure, thank you. Let me just share my screen, if I may. Okay, so thank you very much for having us along. I mean, as usual, really, a lot of what I'm going to say is probably quite familiar to you. So apologies for that. But with winter planning really coming in now, and looking at what we can do to really change the shape of this winter in LLR, we're really getting incredibly focused now on the direction of travel going into winter. So I think it's worth focusing all of your minds. So first of all, this is just a little reminder of the cohorts for both COVID vaccine and for flu vaccine. I'm sure you're familiar with these, but if you're not, and just to remind you, this is the first autumn winter where COVID will not be offered to the groups of individuals who are at risk, who are at clinical risk. So the only group who would be eligible under that sort of umbrella would be those who've got immunosuppression. Other than that, it's a 75-year plus vaccine, and we are going back, of course, to care home residents as usual. Flu, therefore, is a different cohort. It's 65 plus. It does include all those clinical risk individuals and care homes and so forth as well. So much bigger cohort for flu. So whilst you can still co-administer the two, obviously by the nature of it, we're going to find ourselves giving a lot of individual just flu jabs to many people. Looking at the products for flu that have been sort of widely, I think we've been told about them, all trivalent, we think this year. We're not anticipating seeing any quadrivalent vaccines this year. And as you can see in that first choice column there, quite a few different options. We've had previous years where it's been really restricted, hasn't it? If you're not buying the Seqirus products, then you're out, kind of thing. Lots more choice this year. So a lot more interesting information we'll get after this year to see which of these products outperformed the others. There is really no reasonable reason why we should be going to the second choice column. So it's been made really clear that if you can't provide a first choice vaccine for the individual who's presenting to you, then you should be doing everything you can to signpost them to a provider who can, rather than giving them a second choice product. Then just looking at what NHS England are asking of us, quite a few targets this year set by NHS England are quite significantly higher than what we achieved last year during the autumn winter. And I think it's compounded a little bit because what the public tend to do is to follow the sort of lowest threshold approach. So for instance, if you're age 65 and you're being told that 50-year-olds are being offered a flu jab, you're going to think, oh, I need my flu jab. Whereas if the target was that actually, only 65 pluses are going to be offered a flu jab and you're 65, you're more likely to think, oh, well, I'm very young for it then still, so I probably don't need to worry. Likewise, we're seeing a lot of individuals not being offered a COVID jab. That could have quite a knock-on effect on the psychology of whether or not people decide to get vaccinated. So I think we've got quite a big job to do here if we're going to sort of turn things around and improve uptake. And staff uptake is one of the big things where we all need to focus in on our own practices, our own staff teams, and do everything we can to persuade our staff to get vaccinated too. Looking at this is a plea really from the rest of my team, the ones in the background who do all the hard work and organisation. One of the things that they find quite frequently is they'll be into the thick of sort of COVID vaccine supply and so forth, and they'll find that a member of your sort of more local team, PCN team perhaps, on site actually go off sick, for instance, and it could be that they're the only person with FDP access or the only person who knows quite how to manage the stock and so forth. So just a plea to make sure that you've got at least 2 members of your teams able to jump in and do this just in case of staff sickness or holiday. And then this slide is here really because we've had some new research published in The Lancet just very recently, and the link is embedded in there if any of you want to go and have a look at it, which includes research done locally by Damien Rowland here in LLR. And basically it shows that the data is even better than Pfizer suggested for Abrysvo. Here in the UK, if a woman has an RSV vaccine at least 2 weeks before she subsequently delivers, her infant will have a 72% lower chance of hospitalisation with RSV, which is a staggering number. And given how common it is for children to get admitted to hospital with RSV, actually something like 351 children per 10,000 children. So, it's quite a significant number being admitted each year. And that means that actually the number needed to treat, the number of vaccinations we need to give to pregnant women in order to avoid those infant hospitalizations is just 39. So, if you do a clinic of 39 antenatal RSV jabs, you've avoided a hospital admission. And obviously that doesn't even consider the number of attendances to GP land or ED or just the illness that people are suffering. So fantastic vaccines working really well. But currently our best estimate is that only something like 34% of third trimester pregnant women are having the vaccine before they deliver here in LLR. So, this isn't good enough. Obviously, we all want it to be better. And what we found also is that more of these vaccines are being done in general practice than being done at UHL. And you'll remember that at 28 plus weeks of pregnancy, a woman with an unremarkable, straightforward, low-risk pregnancy doesn't have any reason to touch base back in UHL in those central sites. And so there's bound to be a need for vaccination in the community. You can see also on there that we can't be absolutely clear, but from what we can see, this falls the same as it often tends to, where the city vaccination rates are much lower than county and Rutland rates. That poster over to the right of this screen is fantastic. It's the first time we've had a poster that has linked bronchiolitis and RSV and vaccination and pregnancy all together in this way. And I think the word bronchiolitis is quite an emotive word, but it's one that the public understand better than RSV. So I think that poster is probably very helpful. And if any of you want to download it and get it printed off to use in your waiting rooms, that would just be fantastic. A few other details in there about how women can otherwise access the vaccine, in particular our roving healthcare unit, but also they can just walk into those UHL clinics and get their vaccines done there. The other thing in the green box, bottom right-hand corner, is just to point out that the sort of antibodies that are given to very high-risk infants when they're born, that they're changing the product from polivizumab to nirsevimab, which should mean that it's just a one-off injection that lasts for months and months. So hopefully that's a benefit. And we've certainly seen fantastic results from nirsevimab being used in Galicia with really good impact. And they've actually rolled it out. Instead of doing RSV vaccination in pregnancy, they give nirsevimab to all their infants instead. Looking at the older adult population, top right-hand corner, the box of data, there's lots of red, there's lots of amber, there's not much green going on. And that's partly because NHS England have set a 70% target. And that's of that first 5-year cohort that all became eligible suddenly on September the 1st. They ideally would like at least 70% of them to have been caught up and vaccinated. So we've still got quite a bit of work to do to get there. But I'm very much hoping that ahead of the big sort of COVID and flu clinics that are coming up this autumn, that many of us in our practices will be putting on RSV clinics and mopping up as many people as we can that way. And of course, you can include the pregnant women in those mop-up clinics too. The column in red to the right, I'm less concerned about, because this is really just the rolling numbers of the ones who just are becoming 75 years and eligible. What percentage have we hit? And I suspect there's not been so much activity with RSV over the summer months. So probably those numbers are a little bit low because of that. So the sort of cohorts and things also all welcome to go to the roving healthcare unit. Both older adults and pregnant women can access it there. And let me move on to just show you some of the things we'd like you to consider looking ahead now to autumn winter and how you get ready for your patients. And one of the things is to point out that for those older adults who are currently 80 and are awaiting their 81st birthday imminently, those are the adults who've had that extra year of grace to get their vaccine done, even though they've already become 80. That offer will be withdrawn on the 31st of August 2025 or thereafter. So those 80-year-olds will no longer then be eligible. So anything we can do to make sure they have access to the vaccine before then would be fantastic. That's just for that 1-year cohort that we're given the extra year of grace to get vaccinated. The other thing to point out is that obviously from an antenatal point of view, any clinics you can put on in the next month or two are fantastically well timed in terms of protecting babies, giving them a really peak of protection looking ahead into this winter, and RSV peaking in December. Also, just to point out that older adults, if they're going to be offered a flu vaccine, which of course they all will be eligible for, then RSV and flu need to be separated away from each other, ideally. They attenuate each other, is the understanding. So COVID's all right with RSV, but of course we're generally tending to co-administer COVID and flu to this population. So that means ideally the RSV vaccine would be done probably to start with, and then 2 or 3 weeks later, they'd be welcomed back to a big COVID and flu clinic to get the other 2 vaccines done then. And again, great time of year to be catching up with this RSV work ahead of the game. Antenatally, in the age 2 to 3 year flu vaccination campaign starts on the 1st of September. So pregnant women and children, that's when vaccination can begin. And I'm coming on to it in just a moment, but just a reminder for you that actually community pharmacists may start vaccinating 2 and 3 year old flu from the 1st of October. So following in a month later than general practice. And the wider flu campaign, as you'll know, I'm sure, starts from the 1st of October onwards. So we've done a little chart there of what we might suggest you're thinking about month by month. If you'd be so kind, we would love your support on it. Community pharmacy pilots then, so that's what I was alluding to, and just coming on to that, there are 2 NHS England driven community pharmacy pilots going on right now. The first one, the older adult RSV pilot we heard about a few months ago. This is just 15 pharmacies who have been selected specifically because they're in postcodes where there is incredibly low uptake of older adult RSV vaccination. So this is a very much a minority thing. However, these pharmacies are able also to administer it to pregnant women, and in order to give a wider offer to those pregnant women, they are being empowered to give pertussis to pregnant women as well. The appointments for those older adult RSV clinics are only bookable via NBS. But recently, as in literally the last week or so, we've just heard about this other manoeuvre, which is that now children's flu, the 2 and 3 year old flu, whether injectable or nasal in the majority, we presume, is going to be something that pharmacists can, if they wish, start to give. And this pilot will begin on the 1st of October 2025 and will carry on through, I believe, into March, and will then be evaluated, and NHS England will make its decisions about how to move forwards with this. The number of appointments are obviously very limited, as you can see there. However, they are able to offer it up to walk in if they wish to. So we shall see. Interesting. Watch this space. Just to finish off, really, a couple of things. One is to just give you some of the dates of where the roving healthcare unit is expected to be. As usual, currently it's got MMR, pertussis and RSV vaccinations on. Of course, once we get there, it'll be offering flu and COVID as appropriate. And then a final mention of NHS England's HPV vaccination sort of pilots that are going on, because again, there are two. I think regional NHS England set up the one which we've already told you about, which is looking at 16 to 18-year-olds. They've sent you all a list that CHIS have helped them compile, which gives you the name of the young person, their NHS number, but also which vaccinations they are outstanding. All of them are outstanding an HPV jab, but there are other vax on there too. And they've asked everybody to try and do call and recall to target as many of these young people as possible. But nationally, NHS England have now decided that for this winter season, their catch-up vaccination programme, within our contract, is going to be HPV. Last year it was pertussis, the 2 years before it was measles, MMR, but this year it's the HPV vaccine. So this sort of call and recall project is extending over the winter months to up until March the 31st, and it's for everybody eligible in terms of, all the females right up until the 25th birthday, and the eligible males. You remember they became eligible after the girls did. And that's everything from me. So thank you very much indeed for your attention. I really appreciate you having us along.
Brilliant. Thank you, Jen. That's a really good presentation. Really gives us a good idea of what we should be doing in the coming months. I'm sure we're all going to be extremely busy vaccinating. There was just a question or a comment from Sarah Panter just in there about sort of the pharmacy having slightly ahead of us in terms of our GP practices. Do you have any thoughts on that? Or, I mean, it looks like we've got plenty of work to be doing anyway.
Is that with which vaccine is that regarding? Do we know? Was that a flu comment or?
I assume that's probably flu.
Yeah, I mean, the difficulty for me is, I mean, general practice have a 1 month head start, I suppose, if you look at the age 2 to 3 nasal flu. But we all know that nasal flu stock is really tricky. We can never be quite sure when it's going to land in practice and when even we're going to be able to order it on Inform. So no, definitely that is tricky. However, in terms of when pharmacists can begin vaccinating for the broader adult population for flu, it's exactly the same as general practice. So they are not able to have a head start. And the drug companies actually would refute the fact that pharmacists get their stock any earlier. It may have been historically that might have appeared to happen sometimes, but apparently that is certainly no longer the case. And they should receive their stock with exactly the same priority that we do, and they're allowed to vaccinate from exactly the same date. That's hopefully a bit reassuring.
Brilliant, thank you. I think there's another question from Sarah, but that probably could because we need to move on now to our.
So very quickly, the iOS payment's exactly the same. Just to answer.
Okay, fine. Brilliant. All right, thank you. Okay, fine. So thank you, Jenny, for your time, and thanks for all your efforts. Some really useful information there that I'm sure that we're all going to be looking at over the next couple of months. So the next person I have on my list is Rachael. Rachael, are you there?
Yeah, I'm here.
Yeah. Hello, Rachael. Hi. So Rachel's going to be starting off our sort of quite cancer-focused meeting, waiting times in cancer pilot. Rachael, over to you. Do you have your slides?
Yeah, I'm just trying to find.
I don't know about everybody else, but you're slightly quiet for me. I don't know if that's a bit better.
Is that a bit better? Okay.
Yeah, much better. Thank you.
Okay. So I'm just going to cover off. So I'm the GPLO for Vita, NHS Talking Therapies. And there's been quite a few kind of varied external people saying what our waiting lists are. So I thought I'd come on and actually kind of clarify what those are at the moment. Some people have been saying there's 2 to 3 years, which isn't correct. It's actually assessment at the moment. It's about 10 days. So from referral. Then for step 2, it's about 8 weeks to 12 weeks, depending on what the person's kind of basically needed to come to. Step 3, that again varies depending on what is actually needed. But as an average, you're talking about 9 months, which would be for CBT. Maybe a little bit longer, say a year for counselling, but we do have our waiting well service as well. So people can access some support through self-guided online webinars, things like that. So that's something to bear in mind in relation to our waiting times. We're also going to be, we're looking at and have been trying to set up a pilot for cancer. So would really benefit from your support with this by kind of thinking about some patients that might be applicable to you that you've got. If I can, oops, hang on. Right, okay, so the cancer pathway taster session. Okay, so we're looking at needing patients that are at the point of having been diagnosed. They've gone through that 2 to 3 months of just processing the fact that they've been diagnosed. So they're a little bit more kind of on an even keel for that. So the group aims to support the emotional and physical demands of living with and beyond cancer. So it's not just those who've been diagnosed, but those who've also been gone into remission, but also still got that concern at the fact that it might come back. So that's kind of an ongoing battle for them. It's an educational course designed to highlight and provide support for some of the more common emotional and psychological problems associated with living with and beyond cancer. Okay, we've got a variety of options that we can go with depending on the numbers and their location. So sessions could be in a surgery, and so if there was enough people within a surgery that would kind of make up a group, we could do it that way. Or we could do it online. So we've got that kind of option to be able to be flexible. Okay. So what we need from you, if you wanted to take part and help to progress this, is for you to think about a list of patients that would be suitable and want to participate. And following the taster session, we'll support the patient to make a referral into the actual full service and have an assessment to get booked on for the course. Okay, so they can get onto the course, but they would be assessed first of all to be able to check that there's nothing else as well that we can help them with. Okay, as I said, sessions could be online or face-to-face, depending on the demand and the patient's preference and their location. So if we had, say, 3 people in one area, 3 people in another, then kind of it would make more sense to do that online. So inclusion criteria, they've got to be diagnosed with cancer. Patients must be struggling with the distress in relation to their cancer. They will have recently, say 2 to 3 months, as I said, to allow for processing, been diagnosed, and they've got to be registered with a GP in LLR. Patients meet the criteria for our service. They've got to be in case nurse and not be a risk or a low risk. They've got to want to collaborate with Goals for Therapy. They may also have a long-term condition as well, but cancer is the main problem that's of concern to them at the moment. As you know, our service, we ask them to what it is they want to prioritise. So the cancer's got to be the thing that they want to actually prioritise and be their main point of concern. Exclusion. So patients who have cancer, but their depression or anxiety is not in relation to this. Those that present with high risk or self-harm to others, as per our normal kind of outline, really. Currently under secondary or crisis team. Chronic problems, complex, unstable or chaotic. So they've got to be balanced and ready to actually be able to focus and engage. They couldn't be currently suffering from OCD, trauma or social anxiety, currently suffering from bereavement, anger management, alcohol or substance misuse, or any social service involvement currently, domestic abuse and long-standing eating disorders. Okay, so that's kind of basically a little bit of a nutshell of how the pilot will be running. And yeah, we really could do with, as already mentioned by Virginia, we could really do with your support to actually get this up and running. We've tried a few locations so far, and it's kind of, we just need to get that ball rolling. Okay, so yeah, if anybody's got any questions, I can try and answer them, but otherwise I can come back to you.
Yeah, if anyone has any questions. I can't see any hands up at the moment, but I do have a question, actually, a bit of a statement, actually. I think this is absolutely a fantastic service, actually. Something that we've been calling out for LLR for many, many years. I know as previous as a cancer lead that this is an area which we've tried to get support for our patients for quite some time. So I'm really pleased to actually see this being available to them. My one question is, does UHL and have access to this as well, as I'm sure our cancer nurses would be able to identify some patients as well as sort of primary care, because obviously there's a huge amount of need out there with the increasing number of cancer diagnoses that we are having.
At the moment, it's not an avenue that we've gone down. We are going to be working closely with secondary care. So that's kind of something, but it's something I'll take back and ask who would it be in relation to the primary care level of patients that might be kind of accessible through them as well.
Yeah, brilliant. Thank you.
Okay.
Do we have any questions? So let's just look through the chat as well. I can't see anything there, but thank you, and thanks for the update on the waiting times. I think that's really helpful to know actually about the assessment times and having clarification around how long our patients actually wait to be seen. So that's really helpful. And
it can cause a little bit of confusion with patients when they're kind of told the wrong figure, and that's a big one. Then it can put people off. But actually, it depends on what they're coming in for, what they're assessed and what's seen as being necessary, what they want to prioritise. But yeah, it's definitely not 3 years.
Brilliant. Thank you.
Okay.
Thank you for coming.
Thank you.
Anybody else any other questions? If we could email you directly, is that possible, Rachel?
Yeah, that's fine. I'll put my email in the chat before I head off, if that's all right.
Perfect. Thank you. Thanks very much. Our third speaker today is Ben. Ben, thank you very much for coming and talking to us about bite-sized training. And I know that you've done a huge amount of work in this area, so I'm just going to hand over to you and let you tell us all about what you've been doing. So thank you very much, Ben. Please go ahead.
Thanks, Vivek. Can you hear me okay?
Yeah, perfect. Thanks.
Grand. Yeah, I've been doing this a little while now. Hi, everyone. For those of you who don't know me, I'm Ben Noble. I'm a GP at Woodbrook Medical Centre in Loughborough. Been there a while. And I've been a primary care cancer lead in one guise or another for the past 12 or 14 years now. Currently primary care lead for East Midlands Cancer Alliance and with Cancer Research UK. Thanks, I think, for joining me, I want to say, because it's such a lovely day out there. I appreciate your efforts being here for a webinar, a remote webinar when the sun's shining outside. So thank you, and I'll try and make it as worth your while as possible and make sure we finish in good time. So what I want to do is talk about symptoms of cancer. It's a subject that's on our minds as soon as patients walk into our consultation rooms. And I'm going to talk about why they're difficult to assess and what we can do to help ourselves through those consultations, because we encounter cancer symptoms in, I think research shows about 13 to 15% of our consultations. So it's important we have a process for filtering through those and deciding when we're concerned and when to investigate and when it's safe not to. I'm going to talk to you about the Cancer Maps, which is a cancer decision support tool that is available throughout primary care and that I worked on from 2015-16, I think. It started as an idea in my study right here, and eventually became a NICE and RCGP approved tool that's being used nationally now. It's a cancer decision support tool that is designed to help you recognize the signs of cancer while you've got a patient in front of you. I mean, there's other uses too. You can use it for education, obviously. I sometimes use it as a safety netting tool with patients. I'll show them a picture of what we look out for certain cancers in terms of symptoms. But it's primarily there to help us as clinicians decide when and if to investigate certain red flag symptoms. It's available online. I think with AI becoming more prominent in day-to-day use, day-to-day systems, it might be that tools like this will be superseded by integrated kind of learning software, but we're not there yet. And in the meantime, I just feel that these the maps represent the simplest and most unobtrusive way to access best practice guidance. So what I'll do is I'll talk a bit about the NICE guidelines and demonstrate the need for a cancer decision support tool before introducing the maps. And I'll explain kind of how they came about, how they work, and how you can use them in day-to-day consultations. I should have shared my screen really. Where are we? Let's go to that. I think that should be up and running. So the NHS long-term plan was that 75% of cancers are going to be diagnosed in the early stages by 2028. So that's stages 1 and 2. Obvious significant barriers to us achieving that, and I think with the current trajectory we're not going to, but it's aspirational. And one of those barriers being the variation between clinicians in assessment and referral practice. And to support this ambition, the PCN Cancer DARES, which is this bottom right bit here, asked that we review our cancer referral practice against best practice standards, and for Cancer Alliances to do it to establish universal coverage of cancer decision tools. So GPs are being asked to audit cancer referrals and see if any lessons can be learned. And in the meantime, as Cancer Alliances, we're being charged with improving access to cancer decision support tools. Actually, the cancer maps, which I'm going to talk to you about, have been available freely since their inception. Pathway to diagnosis of cancer. It's obviously a very complex process involving interactions between many systems and many steps and multiple behaviors at any of those steps. And you'll be able to imagine how at any point in this process, and you'll be able to see where you come in along here, there will be variations in practice, and we can see how delays might occur along this journey. And by the way, we are relying on the patient to come and see us in the first place before we come in here at the primary care interval. You can just see all these steps before we get to a start of treatment. The best practice in primary care is generally referred to as NICE NG12, which was published in 2015, and it hasn't really changed a huge amount since then. I think probably the main change has been the fecal immunochemical testing. It represented quite a large change from the previous guidelines. Firstly, there was an emphasis on symptom recognition, grouping symptoms together, which might confer a risk of cancer. There was a shift in advice from 2-week wait clinics to direct access testing for some cancers and some symptoms. So GPs now being asked to investigate rather than refer. And probably most importantly, the referral threshold was reduced from a positive predictive value of 5% to one of 3%. And those three factors combined brought in a lot of new advice to these guidelines, and often cancer symptoms to look out for that weren't necessarily intuitive to that organ. We can call them non-site specific symptoms. And it's probably easiest to give a demonstration of those through case studies, I find. So I'll throw this one at you. If we can think about a 55-year-old chap who's come to see you feeling tired all the time. It's quite a common consultation, tired all the time. Falling asleep at work, so proper tiredness. It's been about 6 weeks or so. He's not changed his sleep pattern, no particular mental health issues to explain it. And during the consultation, you ascertain that he's probably not as hungry as he is at usually is at meal times. Systems reviews okay, bowels regular, not got any urinary symptoms, no respiratory symptoms. And so, I mean, I prefer these to be interactive, by the way, but I appreciate it's difficult on a webinar, so I'm happy to take questions at the end. But I like to throw this out to the group, but we won't here. But often when I do, I'll get back answers along the lines of, in terms of what we do next. Well, we'll do some blood tests, and I think that's reasonable. We would examine him first, of course, wouldn't we? And arrange some blood tests, check iron levels, maybe. And let's say they're all normal. According to NG12, we should be arranging an urgent chest X-ray for this gentleman because he's over 40, and we didn't ask smoking history in the consultation. Shame on us. But even if he didn't smoke, he's got 2 of these symptoms on the right here, which are indications for an urgent chest X-ray in an over 40-year-old. If he'd smoked ever or been exposed to asbestos, he'd only need 1 of these, unexplained. You've got to read unexplained in front of all of these. And I think fatigue is often one we miss when it comes to lung cancer, but is a significant symptom associated with lung cancer. And I've been asked before, because I like this as a case study, I present it quite a lot. I've been asked, are you telling me that every time I see someone who's tired, I've got to do a chest X-ray? Well, if you can't explain that fatigue in any other way, yes, I am. And that's what NG12 says. And I think that's probably the important part here, unexplained. Most fatigue that we see is explained by poor sleep. And actually, it's been shown that the more chest X-rays we do as clinicians, adjusted for demographics at any practice, the more and earlier lung cancer we diagnose. So increasing our chest X-ray rates is a good idea. It's a simple test to do. Lung cancer is a devastating illness. It is the highest cancer cause of mortality. And the earlier we can catch it, the better. In fact, we're actually in Colville at the moment. We're running a pilot where patients can request their own chest X-ray if they have any of these symptoms via a phone line. And I'm hoping that we can, because it's going very well. It's been very well engaged with, and we're hoping we can expand that service. Let's have another look at a case study. So let's imagine a 57-year-old lady who saw a bit of blood in her pee, and you dip the urine, and it's positive for blood. And send the MSU off; it's normal. And you do some blood tests, HbA1c's borderline diabetic. Other bloods are all normal, and you've checked your CA125. And on the strength of the visible hematuria, you refer to the urology clinic. She has a cystoscopy, CT of a renal tract, discharge, no cause found. Gynae and urological cancers is quite a crossover in symptoms. This is a good example of non-site specific symptoms, i.e. a symptom which makes you think urinary tract, which is actually relevant then to the womb. And an over 55-year-old lady with visible hematuria and one of these 3, anemia, thrombocytosis, raised blood sugar, should be considered for an urgent ultrasound to rule out endometrial cancer. Or over 55 with vaginal discharge and one of, it's the first time that's happened, over 55, they've got raised platelets or there's hematuria, and that doesn't specify whether it's visible or non-visible, so it can be either. So you can see how non-site specific symptoms are present throughout NG12 and how there's a real challenge sifting through certain presentations, and it's very important that we safety net as we go along. Thrombocytosis, by the way, is I think becoming better known as a risk factor for cancer, unexplained thrombocytosis. And in fact, it's present on the non-site specific pathway as a referral guideline. How about this one? I hope these are helpful for you, because I always find that the case studies go down well, and people can picture themselves with this case in front of them and ask themselves, well, what would I do here? So this is the last one. 63-year-old chap, ex-smoker, raised blood pressure. He's having his chronic disease bloods, his annual check, and you're filing them, and it shows got a white cell, raised white cell count. And you decide, well, let's have another look at that in a few weeks, and it's repeated, and they're still raised. All the other blood tests you've arranged are normal, and you decide to see him in clinic to see if all is well. He feels fine, examines normally. So my next question to the group, and you can ask yourself this without necessarily coming forward, is what would you do? What is your next investigation? And I think probably pertinent here is next, i.e. think about what's going to be the easiest, quickest thing you can do now that might give you a hand. And the answer is a urine dip, or he actually leaves the surgery because you have found that he has leukocytosis. And if he's got non-visible hematuria on a urine dip, he needs a 2-week wait referral for potential bladder cancer. Again, really tricky, and not the first thing you'd think of, but it is there in the guidelines. So you can see why there's a need for a bit of help assessing potential cancer presentations. So the cancer maps, as I mentioned, came to me as an idea when the NG12 guidelines came out. I did what I usually do when I'm presented with a large body of work, and I was a cancer lead at the time, is I mind mapped it, and that's just how my brain works, to get my head around large volumes of work. I like to see it all on one page if possible, or I'll do a couple of mind maps, and that's kind of how I've worked and took my lecture notes in university, etc. And while I mapped NG12, I just thought, well, it lends itself pretty well to this way of thinking. It's quite algorithmical. You know, if this, then this. If you've got this and this, then this, and it worked quite well. They came out quite neatly, which is usually a good sign that they'd make a good map. And so I kind of did them in neat in my scrawl, and photocopied them, handed them around to colleagues at work, and got some nice feedback, said it was useful. And then I was challenged to make them more widely available to people, and so I found a bit of software called iMindMap, and managed to put them on that and a digital version. But they weren't web enabled or anything like that, so I just printed them off again for people. It was only really when my dad retired. My dad's been in computers all his life, and he was able to help me web enable them and add extra features that they became more useful to more people. We just have a look at one map. So we've got all the organs in the center. It's based around 3 mind maps. We got all the guidelines on 3 mind maps. In the middle, we've got the organs. The second branch is the advice from NICE, whether it's a referral or an investigation. And as we come out to the periphery, you'll see the signs and symptoms associated with that organ and with that advice. On the top of the screen, you'll see a toolbar, and in there you can populate the age and gender of your patient. And on the right, you'll see all the signs and symptoms that are present in the NG12 guidelines. You can click on any one of those and put in your filtering gender and age details. And I'm sorry, I've used screenshots here, but it's just easier than coming out of PowerPoint and then showing you and then going back in. But if you click on any of these signs and symptoms on the right here, they will start to flash red where they occur in the guidelines. And in the middle, you'll get a hit number for that particular combination of symptoms that you've selected. This one I've just selected weight loss because it's got lots of hits. It's just to show you how it works. In the middle, around the organs, you'll see these information icons. You can click on any one of those and bring up a load more information about that particular cancer, how common it is, survival data, risk factors, and then links to Gateway C's educational modules. So this is on the Gateway C website, and they've got some excellent educational modules, videos on there. Recommend it's available for free for everyone in primary care. I recommend you, if you haven't already, register an account with them. There is another function of the maps, which I'm going to show you via another case study. So think about a 71-year-old ex-smoker with 7-week history of nausea and weight loss. Examination, your blood tests, urine dip, fit, chest x-ray, all normal. Do an ultrasound, normal. And because of the nausea and the weight loss, you refer upper GI. Actually, I think this has aged badly because now you'd probably send to the non-site specific, and that gets around that. But humour me. So they have an OGD via the upper GI pathway, which is what used to happen, and they'd get discharge, no cause found. And if you see this ultrasound abdo NAD, this is just to point out that the false negative for ultrasound and pancreatic cancer is 30%. And to point out that these important false negatives are present via these orange exclamation marks on the maps. So all the common investigations that we do in primary care to investigate cancer, there is a false negative there, which helps you to decide the how much suspicion to retain for your patient. So that's it in a nutshell. I still use the maps despite having most of NG12 imprinted on my brain now. I still use them because combinations of symptoms are difficult, and I find them easy, simple. They give me immediate advice. I'm not looking through text, reams of text. I'm not kind of doing searches on Google to try and find out age ranges and symptom signs. And they're there to use if you want to. What I recommend is most of us, most clinicians have 2 screens at least these days. I go for 3 myself. You have your patient notes open on one, and you have your helpful websites tools open on another. And I recommend just having the maps there as something to use if you want to. It reminds you to look at them just because they're there, if you can remember to open them up each time. And you're not getting nasty pop-ups telling you you should be doing this and that, because my experience is, I mean, I hate that. I will rebel against any pop-up, and my experience is most GPs feel exactly the same. It is the only cancer decision support tool to be endorsed by NICE and Royal College, and it's Gateway C's most visited page. It's getting about 3,000 hits a month. So I think people use it and they like it and they go back to it. So all I say is, I mean, I don't claim it's for everyone, but have a go, see what you think. We did pilot it a while ago amongst a group of about 40 odd GPs. And I mentioned it does have other uses beyond just a decision support tool like educational and safety netting, but it was primarily used as a support tool. It provided new knowledge in a third of uses. So the more it was used, the better the knowledge of the clinician using it. It was very popular, most would recommend it, and the vast majority felt more confident making their referrals. Perhaps most tellingly, more than half made referrals that they otherwise wouldn't have if they weren't using the tool. That's the link to the maps. Please have a go. Please tell your teams at your practices. I find that juniors, trainees really love using this. And it's a real aid. I'm a tutor for foundation doctors. They absolutely love this because they're coming into general practice cold and they're scared about missing stuff. So they really love this. And any feedback, that's my email address there. Always happy to hear from people who've used it, and happy to consider changing it if people have ideas to improve. Thank you. Has anyone got any questions?
I can see one hand up. Is that Vipul Mashari? Can you go ahead?
Yeah, you know, when I listen to this, and as you mentioned, AI, and we're starting to look at Heidi doing the transcribing for us. You can see the integration could occur where Heidi is listening for the keywords and then pinging up. Have you thought of this? I mean, the fever score thing, that whenever you write down sore throat and the sodding thing comes up, and I don't like those, but this is really an opportunity. Is there any work being done with people like Heidi to say whether there's any integration possible? Because we're not asking a lot of it, are we, really? You're just asking it to listen to keywords.
Yeah, I can't tell you, Vipul, if that's happening, but I'd be amazed if it isn't. The difficulty, I mean, I'm often asked, have you tried to get this integrated in System 1? And the reason I haven't is I don't want pop-ups, because this kind of thing kind of starts to generate pop-ups, and B, I'm only me, and I don't have a computer background. My dad kind of maxed out where he was with programming. He had to learn a lot of web enabling from scratch in order to be able to program this. And so, you know, we're not a company trying to grow a product, but if we were, that would be the obvious thing to do. So yeah, I mean, I foresee a time in the not too distant future where tools like Heidi will take over our jobs. I just think it's inevitable. The AI is becoming cleverer and cleverer, and it will eventually know more than us. It won't have gut instinct and stuff like that, and you will lose something, obviously, but you will massively increase coverage for people and appointments. So yeah, it'll be happening somewhere.
My view of AI and all this is that if you can get, say, if you've got prostate cancer and the fella who's the best at managing your cancer is in California, and he can do the robotic surgery and give you the treatment, then why the hell not? I think this is about enabling. We can do the caring, holding the hands, understanding, explaining, but you know, isn't it a fantastic future for medical practice that we'll have a machine stopping you falling into the potholes where you make a mistake, and then because you just didn't think of it, you know, rare things occur rarely, but they do occur, and that's when you bloody well forget it, don't you? That's the problem.
Yeah, I think it's fine when it's supporting you. I think there's a fine line between that and being intrusive. You know, when it starts pointing out things that you had already thought of, and it starts to get a bit annoying then, and then pop-up fatigue or whatever it's going to use to tell you, you start to ignore it when it might be saying something useful. So there's challenges there. But I think that's probably the next step, yes. And then after that, it'll just take over entirely.
Do we have any more questions? I'm just going to just check the chat. I can't see anything in the chat. Just say that we have put the mind maps sort of link in there. So thank you, Sabina, for sorting that out. We do have a question from our observer. It says, with increased referrals to cancer specialists, how likely are clinicians able to identify malignancies at an early stage or precancerous stage?
Well, I guess that question is more aimed at screening, isn't it? Pre-cancer, before symptoms. And there's a lot of research going on multi-cancer detection tests, looking at genetic changes and things like that. It's not there. It's in process. I think the initial results have been disappointing. There's the vast potential for over investigation, over treatment, and we've got to be mindful that finding an indolent cancer is not a victory. We have to be able to tell when a cancer is going to cause harm, and if it isn't, we don't want to know about it. And so that's a really big challenge for any future investigations. And we look at some screening. I mean, breast screening only gets a weak recommendation from Cancer Research UK. There's a lot of harm comes from breast screening as well. A lot of indolent cancers, over treatment occurs. So yeah, initial stage, precancerous stage. I mean, prostate's an obvious one for that. It's got a huge sojourn period, up to 15 years, prostate cancer, and there ought to be a way of diagnosing it earlier, but there isn't. And we've known this for ages, and there still isn't anything. And so therein gives you an insight to the difficulty associated with that. And then when we do diagnose it, we're still not sure whether we should treat it or not. There's not a general agreement.
No, thank you. That's certainly true. And thank you very much for the presentation. It's an excellent presentation as usual. Also very worrying. I've now got to go back and think about all the patients I need to go away and think about to maybe re-refer. But just to highlight, the Gateway C is free to all clinicians, and you're absolutely right. Our trainees love it. It's really good in the mixed economy now that we have within primary care as different clinicians. So I'd recommend it to everybody. I don't see any more hands up, so and it is a lovely day, and we are 1 minute over our prescribed sort of time. So I just want to say thank you to all of our presenters for coming in and giving us some excellent talks, and thank you to everyone for attending, and I shall let you all go. So thank you very much, and we'll see you in 2 weeks' time.
Thanks, Vivek.
Thanks. Bye-bye.